Welcome, everyone. Thanks for joining today. Hello, hello. Thank you for being a part of our World TB Day commemoration. We'll begin in just a few moments. Get yourself settled. You have a few moments to go refresh your coffee, grab a cup of water. Hello, everyone. I'll Well, greetings and thank you for joining SNTC on World TB Day. I'm Karen Simpson, the co-executive director of SNTC. We have a great lineup today as we observe World TB Day. First, Philip Wegner from Illinois will provide a review of the 2025 provisional TB data. We'll conduct a few polls and then recognize the illustrious career of Dr. Charles Peloquin. We'll end with a Q&A session where you'll be encouraged to join in the conversation or chat your comments. As everyone joins us and settles in, I'll provide a few announcements now. Here's a brief agenda of what we'll be going over today. And have you seen our TB avatars? SNTC's World TB Day AI avatar generator has been a big hit. Here are a few of the 291 avatars from TB staff worldwide that have been shared with us. Have you tried it? There's a link in chat to guide you through creating your own avatar. I hope you give it a try. Now, just a quick reminder about SNTC's upcoming courses. You can always find information about our events on our website. We'll place the link in chat. I'm sure you know someone who would benefit from joining one of these upcoming courses. We'd love to have them join us. Please share the link with them. And without further ado, it's my pleasure to introduce a TB expert who will share the 2025 provisional TB data. Philip Wegner is the section chief of TB and hepatitis for the Illinois Department of Health. He's had a long and interesting TB career that's included work in 20 countries, not including the US. He's traveled to 55 countries and worked in 13 different TB programs, including USAID and Doctors Without Borders. He's worked in 3 state TB programs, Oregon, Wisconsin, and now Illinois, and 1 county program in California. He has a BA in religion, Greek, history, and English literature, and a master's of community health from Liverpool School of Tropical Medicine. He has a love of TB and history, and we thank Philip for joining us today. Philip, take it over.
Thank you. I will replace the current slide.
Thanks.
All right. I got to do a couple things here. I can't do it here. There we go. Swap and hide. Should be able to see it now. Do you see my presentation?
Perfect.
Oh, great. Okay. So I talk kind of fast, but we can't forget that today is World TB Day and that Robert Koch redefined TB as the presence of a mycobacterium, an organism. And this was on, of course, March 24th, 1882. But we shouldn't forget there was someone else in 1882 who proposed treatment. Carlo Forlanini from Italy proposed an artificial pneumothorax. It was eventually used quite widely in TB sanatorium in the 30s and 40s. It wasn't for everyone, but I can tell you that it saved my grandmother's life because she had TB and was in a sanatorium. We'll look over at Global TB 2025 report. So 2024 data is the current one for WHO. I look at it both now and then 10 years ago. So let's compare. So now there's about 10.7 million cases, and 10 years ago, 9.6. So it actually went up. In terms of deaths, 11.4% of those died. And 10 years ago, it was 16%. We're getting a little better on the death part. HIV is the incredible progress. Only 620,000 reported, 5.8%. 10 years ago, it was 12%. Deaths were 24% of those now and 15% years ago. So HIV TB still kills people. Um, in terms of um, in terms of MDR TB, 390,000, 3.6%, 5% 10 years ago. In terms of deaths, 42% of MDR TBs died this current report, but only 40% in 2014. So MDR and HIV both are killers of people with TB. Let's look at about 2/3 of all TB is in these countries. As you can see on the map, China, Bangladesh, Philippines, Indonesia, India, Pakistan, Nigeria, and the DRC, Democratic Republic of Congo. In terms of incidence, the greatest numbers of incidents, the highest rate of incidence is definitely in sub-Saharan Africa, Africa below the Sahara Desert, and in East Asia and Southeast Asia and South Asia. So India, Pakistan, Philippines, and so on. In terms of MDR, these are the high areas. India, definitely the most, but Philippines and Indonesia. When I worked in Indonesia, 1 out of 7 TB patients was MDR TB, which is quite high. China and also the Russian Federation. This was reported in 2023, not reported this last time, but I bet this was countries using the BPALM regimen or the all-oral regimen. You could probably color in the United States and Canada now for this. I just wanted to show you this because although it's widely used all over the world. And as a result, we've got this study from early 2025 that showed that 70% among 88,000 isolates, 70% were resistant to bedactylen across 4 continents. And sadly, 4 countries showed resistance to the whole regimen. Oh, excuse me, let's go back here, look at. So the whole regimen. And these were Belarus, Georgia, India, and South Africa, the red stars here. And this is, a warning to us. We're running out of time. We've got to get TB treated in time. We all aware of the funding and lack of funding. And this is a WHO 2025 report on the funding. And you see in the dark blue, that's USAID funding, which has virtually disappeared for TB. And in the brown or red, this is the Global Fund. And the largest contributor to the Global Fund is who? It's the United States. So you can take away some of that red and all of the blue, and you'll just get the light blue, and you can see how great an impact it will have. It will have all these areas that WHO identified: screening, diagnosis, preventative treatment, data systems, patient support, referral systems, and you can probably add treatment and supply chain into that as well. So it's going to even be worse. There was also a recent study in 2025 showing that A and B, what the lines here, if there is no recovery of funding, the red line shows what will happen with incidence and mortality rate. And also, if there's no funding recovery, we'll have 10.7 million new cases. We'll have 21 million cases of TB, and we'll have 2.2 new rate of deaths. Will be about 3 or 4,000 million deaths per year. So it's a very serious thing we're all facing. Now let's look at 2025. So every year, TB Day, CDC comes out with provisional data. These will change, of course, as we get more clarity and finalize our reporting every state. I took a previous map and added a previous chart and added the 25 data to it. So this is how it looks. We saw the first decline in quite a while. 10,260 cases. Last year, there were 10,393, I believe. And the rate was 3.1 last year. This year, it's in 2025, it's 3.0. Showing the up and down percentages. So this past year, we saw a 1.8% decrease and a rate decrease as well. I usually don't like this map. So what I do is make my own. And so I made my own here. And you can see in the very dark green are the states, including Florida, with the highest number of TB cases and also the greatest population. So it makes sense. But you also can see in a lot of other states the next kind of green, darker green in Washington, Oregon, Illinois. Illinois, we had 384 and 25, and I can tell you we had about 20 that weren't counted. So we were probably close to 400 in our cases, which is a 9% increase for us. So also, I don't like this one. So I do my own. And again, we have the rates for TB in the United States, and it's a 3.3% decrease overall. And you can see the darker purple and the very dark again, but Florida's doing better than the California and New York. And though New York is combined, usually the state is much less than the city. So the city data for New York City hasn't come out yet. This is just something I did this last year. I looked at where the increase was and what percentage. You can see 100% increase in Wyoming. Well, they only had 2 cases. So, so if they have 1, it's a 50% decrease. So this is just this map of the darker color showing the states that had an increase in the percentage. And then we look at this next year here, a lot less darker color, a lot more blue. So we all had a bit of a decrease in the number of our rate, except Illinois and Texas and California. Florida stayed the same. Again, this is the rate in US born and non-US born. And we all know pretty much the non-US born, the rate is 15.4 for the United States, 0.8 for US born. I think nationally it was 77% are in non-US born. For Illinois, that is 88%. I also took their CDC's previous map, added 25 to it, and you can see by age group, 33%, definitely between 25 and 44. But you look at 44, 45 and up, represents 52% of all the cases. So we do need to look at older population who have been immigrated maybe with TB infection and developed TB disease because they got cancer or they got diabetes, even in our own population in the US. This is a native Hawaiian or Pacific Islander for, I think it's US born. I can't see what the table here. Oh yeah, US born persons, definitely Hawaiian, native, and Pacific Islander, the high, but African American, Native American, also pretty high. Just a reminder that the Federated States of the Pacific Islands, Marshall Islands, for example, 250 per 100,000, they don't need a passport. They can come to the U.S., and many of them have come here and work here in different places. So that's a key population to look at in your state because they are in a lot of states. They're even we're in Wisconsin where I worked before, and I didn't realize there was a small group of them that worked at a factory there. And non-US born, definitely the same, pretty much the same, except multiple race. They haven't classified that yet, but there was a decrease in the rates for Native Hawaiian or Pacific Islander. This is interesting because it looks at both US born and non-US born by age. And it might be a little hard to see, but you can see the dark green is 65 and over, and that seems to be in the top of both US born. Except for a spike in very, very young that happened in the United States in probably 2024, 2023. And this is a reminder that epidemiology is alive. And so when you were born isn't now, it's then. So for example, someone born in 1947 in Illinois has the same rate of TB as Burundi, Africa today, actually higher rate. So if you had someone standing before you in your clinic who happened to be born in 1947, they had a bad x-ray, you probably should think TB because that was the era that they were born, and there was simply a lot more TB. If you were born in 1955, that's 61.6% in Illinois. That's the same as Rwanda. So you have to look at the epidemiology in your state and figure out when people were born and what was their risk when they were young, because they may have been exposed, even though nowadays they probably wouldn't be. So overall, the summary of the data over the last 4 years of increases, we finally saw in the United States a decrease by 1%, 1.8. California, Florida, New York, and Texas continue to contribute a major part of the TB, 50%. But rates in Arkansas and Kansas and Minnesota definitely dropped back to the national level. 77% of cases were in non-US born, and you have to look at your own state and see what those are. And like I said, in Illinois, it's 88%. Native Hawaiian and other Pacific Islander persons, Black and African American persons, and children under 14, you have to watch. They declined actually, which is a good thing. And then just remember, it's a bacteria, mycobacteria. It's not a killer rabbit. Thank you. Any questions?
Thank you so much, Philip. We'll take questions at the end, so hang
Okay.
on. Now, as I share my screen quickly, now we're going to do a few polls. So bear with me a moment while I pull it up. So we have a few polling questions to ask, and everyone, you'll have 30 seconds to answer each question. So get ready to type in. It's a fill in the blank, and Dave will help review the feedback. So first one launching right now.
So Karen, first of all, good afternoon and welcome to all of our TB family. It's so good to be together. And I thank you so much for joining us on World TB Day. And I want to thank you up front for everything you guys do. You know, this first question, what challenges within the past year, is really important. And as you know, it's been a pretty crazy year. And as Philip has pointed out, you know, there could be some very dramatic changes that have already been put in place that are already starting to, you know, percolate and challenge us. And, you know, I think one of the things about World TB Day is to highlight what challenges we're having, and also always make sure as a group that we can at least address them and overcome them. So let's see, what do you got? Alexis, Karen, let's show it.
Okay, here we go. Thanks, Alexis.
All right, and you can see there, and these are always, you know, first of all, thank you to the 91. You know, but you can see that the way this works is these are all different words or phrases that people put in, and the bigger the font, it means the bigger more people said. So as you can see, you know, funding has really definitely been a challenge, and you know, this is going to be a you know a kind of a plug for our expert network meeting soon, but you know, one of the things that's happening right now, I mean, on top of, you know, funding being stable and obviously level is not the same because it means cuts, but we've also found challenges now in prices of drugs and obviously inflation. So it's definitely been an issue. And you can see other things like patients are, you know, our patients have always been a challenge. And on the other hand, they're our biggest blessing, you know, and then you could see things like social barriers. But yeah, totally agree. So what's question number 2?
Bear with me a second while I get.
All right.
There we go.
So the next
Thank
thing
you,
is, what
Alexis.
challenges do you anticipate for the upcoming year? I mean, we're already 1/4 of the way in, you know, and as you know, with everything going on in the world, we're not, you know, we're not isolated, and you know, there's a lot of things going on, a lot of uncertainty. As you remember throughout the history, you know, Philip one of the things I always have enjoyed with Philip is definitely his love of history. And, the bottom line comes down to is that TB has been notorious in times of turmoil, in times of upheaval, TB comes back. So let's see, what do we have? What challenges do you anticipate? All right. Again, I agree. I mean, I do think this is one of those things that if we put up this slide 10 years ago, 20 years ago, 30 years, first of all, we didn't have the pretty graphics. It would have been one of us drawing or writing, and we wouldn't have been able to read any of it. But the bottom line, as you can see, is funding, immigration, definitely, with everything going on right now, I think we'd agree we're very uncertain. It's become a time now that you don't really know where your patient is when somebody misses a dose. Your mind starts going to a lot of things that are happening right now. But as you can see, shortages, resources, funds, we have a lot we're going to deal with. And I guess the reason for these questions is to remind you that we're here together. We've always had challenges, but we have to step up and we have to lead. It's going to take leaders, all of you, field workers, clinicians, and all of us clinicians in order to overcome these problems. So now, the most important question is coming up, and this is one that must be answered. Ready? What is the average airspeed velocity of an unladen swallow? And that is unladen swallow. And this is for all the old men. All week, me and Chuck have been taking such from Alexis, reminding me how old I am and how uncool it is to be a Monty Python fan. But there's a key to this Monty Python stuff because it's what bound me and Chuck together. Most people think that we bound over things like drugs and pharma. No, I don't understand anything he talks about. He bores the hell out of me. But what has brought us together is this Monty Python. Any Monty Python fans out there? And luckily it's muted because I don't like the sound of crickets. But that's where we're going to be today, if that's okay. We are here to pretty much talk to what I think is one of the pioneers of TB. Last year we got to talk to Rick Irvin and learned about him. And I got to tell you the story about Chuck. So Chuck goes, "Bring out your dead." Yes, but the maybe not yes, but no. But the bottom line comes down to is oh, I love it. I love it. You got to love that chat. Okay. So the bottom line comes down to is that, I don't know about you, but everybody has a different reason why you went into the career, why you became a nurse, why you became a doctor, whatever. But my philosophy growing up, and we're just going to leave it there for the sake of my reputation, which I don't have any. But and of course the answer is European or African, and then you get genital. But the bottom line comes down to is that my philosophy going into medical school was better living through pharmacology, and we're going to leave it there. It was the 70s, but the bottom line comes down to is that when you went to medical school, pharmacology was the thing you didn't want. It was always difficult. It was tough, and when they always left it for the end. It was usually at the end of your second year, and you always worried about pharmacology because you knew they were going to present concepts you didn't understand. You had to memorize. You had to sit there and try to take all that biochemical and organic chemistry stuff, and I can't. And the bottom line is that your eyes just glazed over. But what's funny? Somehow you get through pharmacology. You don't remember any of it, but you go through it. And it's so funny because everything changes. When you go into residency, when you become a physician, when you're training, pharmacology becomes different. It's a bunch of memorization, and all you're doing is memorizing the number of milligrams per kilogram, especially if you're a pediatrician, right? And it was always one size fits all, And it was challenging. It was so challenging that when I went into training for critical care, they knew that the pharmacologic nightmares and warfare that we created in the ICU was way too much for us lowly pulmonologists and critical care. And they brought in the knight on the white horse, right? They brought in the pharmacist. And that was the thing that struck me most about critical care, is that when you rounded, you always had a clinical pharmacist. How beautiful was it when you had to make a decision, let's start the antibiotic, and you just turned to them and said, you start it. You started the clinical pharmacist. They would scratch it out, they write the order, and then I just came by and signed it, right? And it really, really did influence me tremendously. As a matter of fact, when I went on to take on the role of being the medical director of A.G. Holly, the last of the TB sanatoriums, our challenge was to take care of those patients that could not be taken care of in the community. And if you think about why do people fail TB therapy, there's 4 reasons, right? Actually, there's 10 reasons, but 1 through 7 is not adherence, right? A pharmacology issue. And then number 8 was inability or malabsorption or increased metabolites of drugs or metabolic interference. And it became a nightmare. It became a nightmare. And it was such a nightmare that I decided to go to National Jewish. And at that time, I want to stop for 1 second. I don't know how many National Jewish people we have on the group, but I want to put a tribute out there to what National Jewish Hospital has meant to the field of tuberculosis and to their patients. And they've trained so many of us through the years. It was the place we used to go. It was our Mecca. We would go there all the time, right, to learn, to be trained, because that's where the patients were. And that's where these were these amazing, amazing, amazing clinicians. Mike Eisman, John Sabaro, Gwen Hewitt, Dr. Heifetz. I mean, I can go on and go on. And I remember that at the time, back in 1994, when I started, there was no other place you could really go to train. It wasn't like we had centers of excellence. You had to go to National Jewish. You had to go to Denver. And the problem is very few people had that ability, and I got that ability. And in November of 1993, I was able to go to National Jewish. And there I met some people that would influence my life forever. Actually, some of the other people in the class was Andy Vernon from the CDC, right? We had Jeff Stark there. I mean, the godfather of pediatrics, right? And I remember sitting there and I heard somebody speak and they influenced me forever. And that person was Chuck Peloquin. Chuck Peloquin blew my mind. He actually, instead of taking concepts that were way above my head, he could simplify it. He can make it funny. He would quote Monty Python. Afterwards, the group of us went actually out for drinks, and adult beverages. I was at the time, I just turned 20. We all went out, we all got to know each other and we met. And that started the beginnings of a wonderful relationship, a relationship where I've always been able to trust and rely on Chuck. And over the years, we collaborated. First of all, I got my mini Chuck. I got my Jerry Jean Stambar at A.G. Holly. He convinced me that I needed a pharmacist, and she's amazing. And on the other hand, though, we've been able to collaborate. We did research, and on the research, there was a doctor who really was a major influence to Chuck. And I want to just take a second here and just talk about him. That was Roger Jelliffe. Roger Jelliffe was a man way ahead of his time. This was a guy who believed, he was a cardiologist actually, and anybody who's ever prescribed digitalis knows that digoxin's very hard to get levels, and people always got sick. Matter of fact, the biggest limiting factor of digoxin was always, what's the right dosing? And he got really interested in dosing, and he actually developed a whole field of therapeutic drug monitoring and became a pioneer of that field. As a matter of fact, I read an interview once, and it influenced me. And I'd like to kind of share it with you, if it's okay. And this was in the International Association of Therapeutic Drug Monitoring and Clinical Toxicology. And they considered him a superhero status, superhero. That means something now in 2026 with all the Marvel stuff, superhero status. That's the avatar of Roger Jelliffe. Few people have made it to that status. And they asked him something that I think still rings true. And they asked him, what do you consider the biggest challenge that we face, in therapeutics. And he said this. He said, I think the greatest challenge we face is the strong tendency shown over the last 60 years to resist quantitative approaches in medicine. The biomedical community and the medical school curricula have simply failed to respond to the quantitative advances in PK/PD, which have been made in the last 60 years. Clinical pharmacology used to be a respected medical subspecialty. Now it is dead. The biomedical community and the medical education simply have failed to keep up. There are not enough trained people now to teach clinically meaningful quantitative methods such as PK and decision theory to medical students where the teaching should begin. We continue instead, decade after decade, to turn out untrained physicians who have no idea of the proper use of drugs for patient care. He said, I believe because it is he said that, it was going to take somebody, a society or a person that would once and for all stop the one size fits all approach to drug therapy. And he said that, these new techniques, these new understandings could really maybe one day be translated into real changes in clinical medicine. And Dr. Jelliff died in 2020, and actually the American College of Clinical Pharmacology in 2019, right before his death, actually established the Dr. Jelliff Lifetime Achievement Award. And it recognizes individuals who have significantly advanced the field of personalized medicine by improving the use of drugs or biologics in patients. And the reason I'm telling you this is that one of the greatest honors, one of the greatest things that I really have ever been asked to do is to write a letter of nomination of Chuck Peloquin for this award. And if it's okay with you, I'd like to just read, and I know I'm going a second, but I think this letter, which I'm a terrible writer, as you can see, I'm from Brooklyn. I hardly speak English. But this was one of the easiest letters I ever had to write. And I think this letter summarizes Chuck Peloquin, who's my superhero. And I write this letter as support for Dr. Charles Peloquin's consideration. And you got to love this, because this is for the American College of Clinical Pharmacologists, right? When you write a letter of nomination for somebody, it's important that you get the terminology right. So I want to write this. It says, I write this letter of support for Dr. Charles Peloquin's consideration for the American College of Chest Physicians. What? ACCP. That's what I'm thinking. I can't even get it right. This is a letter. This guy, how they can't expect. They can't believe the person who writes this. But I wrote, as a pulmonologist and medical director of the state of Florida's TB program for the last 30 years, I've had the opportunity to treat thousands of patients with TB. One of the most important lessons I've learned over this time, just as any other craftsman, I'm only as good as my tools. When it comes to TB, most clinicians have at one time or another appreciated the very valuable tool of serum drug concentrations to guide our therapy to maximize our patients' outcomes, as well as minimize any adverse effects. While TB therapy traditionally utilizes a cookbook, one-size-fits-all approach, those of us responsible for curing all patients with TB recognize an individualized approach is necessary to ensure that every patient is cured, even those that do not respond to the usual approach. That is where TB clinicians rely on our special tool, serum drug concentration. When any of us think about training and knowledge concerning serum drug concentrations, one name comes to mind, and that is Dr. Charles Chuck Peloquin. In my mind, the godfather of TB pharmacokinetics. Dr. Peloquin has had a distinguished career. That one I lied a little. All right. But Dr. Peloquin has published hundreds of articles, conducted numerous studies, and has written many clinical reviews and chapters in leading peer-reviewed medical journals in the field of mycobacteriology, pharmacokinetics. He's a regular presenter at most major national and international conferences dealing with mycobacterium. He's received numerous NIH grants and has regularly relied upon us for pharmacologic expertise to provide recommendations for the development of clinical guidelines for the leading medical organizations in the field of mycobacteria. Dr. Peloquin is also known for his laboratory that he and his staff established and is acknowledged to be one of the premier pharmacokinetic labs in the world. His lab processes thousands of specimens from hundreds of TB patients every year from the United States, as well as the world. Chuck has published extensively on this work and has been instrumental in bringing attention to the TB community about the occurrence of lower than expected serum levels in patients with TB and how it contributes to poor clinical responses and or the development of resistance. He has advocated for more effective dosing of our TB medications. The rifamycin, a key component of tuberculosis therapy for the last 60 years, is a known inducer of the liver's metabolism of other medications, reducing their effectiveness. This interference often restricted the use of the most effective medications used for the treatment of other concomitant illnesses that TB patients may have, placing the patient and the clinician in the difficult position of having to choose what disease they would rather have treated effectively. Through the research and work of Dr. Peloquin and his staff, assays have been developed that would allow or can allow for the safe and effective therapy of these concomitant conditions. Through the work of Chuck and the staff of his clinical pharmacokinetics lab, clinicians had access to these concentrations. Recommendations made by Dr. Peloquin and the staff give guidance to the best dosing to maximize outcomes for that particular patient. Armed with these recommendations that were provided, armed with these, clinicians could successfully treat TB patients with concomitant conditions such as HIV, hepatitis C, and invasive fungal infection. Chuck is an outstanding teacher and consultant who's always available and has been sharing his expertise with the TB community for over 30 years. I can confidently state that through Dr. Peloquin's contributions to the individualized care of patients with TB, thousands of lives have been saved or made better. I proudly submit Dr. Charles Peloquin for consideration for the American College. I get it. Chest Physicians is not clinical pharmacologist. Roger Jelliffe Individualized Therapy Award. I am confident that Dr. Peloquin's life work has resulted in accomplishments that have changed for the better the field of TB. I believe that Dr. Peloquin's selection would be an important statement of appreciation to an essential discipline of the TB community that often goes underappreciated, the pharmacologist. In the tradition of those who have previously bestowed with this honor, thanks to Dr. Peloquin's accomplishments, the TB community has forever been changed for the better. Well, I thought it was a good letter. He didn't get it. No, he did. He was bestowed the honor in 2024. I didn't know any other way to say this. And I when this whole idea came up, what were you going to do for World TB Day? I didn't think there was anybody better than to really get to talk to us about what Chuck has meant to all of us in the TB community. Our brother, Chuck Peloquin. Chuck, thank you very, very much for being willing to do this.
Well, thank you.
Let me just do a quick slide here. There we go. That's for you, Chuck and Dave.
All right. Well, thank you for that introduction. Unfortunately, we won't have time today for my talk, but that was really, really nice. Really nice. Appreciate it. So on with the show. So how did we get here anyway? Pharmacokinetics and TB. So that's my title slide. I don't have any relevant disclosures. Our lab is not for profit, and I don't work on commission. So how did we get here? Well, first there was the Big Bang. Then there were dinosaurs. Then there was the Roman Empire. Then there was the discovery of liquid dinosaurs. Then there was D-Day. And then I was born. What? I was hungry. So it's very important to choose your parents carefully. So I did the best I could. And so you see here my mom, Alita, who is a dental hygienist, and you see my dad getting his captain bars for the police department at Chicopee. On the right front is my brother Tom, and you can see me in the lower left, really, really excited to be at this honor from my dad. And then my younger brother Doug was still a player to be named later. All right, it seems that I'm not advancing slides here. All right, there we go. So shaping my behavior. This is Tom at a later date with my mom on the occasion of her 90th birthday, and that's my cousin Greg. And because of these two individuals, I have a terminal disease. I am a terminal wise ass, and there's nothing that can be done. Off to school, just like Billy Madison. So I went to École Saint Jean d'Arc in Chicopee, Massachusetts, the School of Saint Joan of Arc. And you can't get more French than that. Once you invoke Joan of Arc, you've pegged the detector, you're at the max, right? Um, and I grew up in Little France, which was next to Little Poland, which was next to Little Italy, and on the north side, Little Puerto Rico. So by the time I graduated from high school, I could swear fluently in 5 languages, and I was very proud of that. Speaking of high school, I went off to Cathedral High School starting as a freshman in 1973. This was a college prep school, and true to their word, I got prepared for college. So from there, I went to the University of Connecticut starting in 1977. At the time, it was a 5-year bachelor's program to become a pharmacist, after which you sit for the boards, both the state licensing and the national licensing or national exam. So I went through that entire process. It's a very nice picture, I might say, of the University of Connecticut. While there, I met Sue. So Mrs. Peloquin, also known as Susan Mary Doherty, was a business major. So we had no classes in common, which was helpful because we couldn't sit there and grouse about the last exam we had. And she went on to be an insurance claims adjuster. Less formal but very important education included comedies such as Young Frankenstein and the heretofore mentioned Monty Python and the Holy Grail, with great lines like, "I'm not dead yet." After some work in Hartford, I did a residency at Duke University Medical Center in Durham, North Carolina, and stayed on their staff for an additional year. And from there, more education. I went back to get a PharmD because it was becoming clear that that was going to be the standard degree in the years to come, and that did come to pass. You can see from the sign here that the PCP&S was established in 1821, and Sue and I were just in Philadelphia prior to the NAR meeting, or North American Region of the TB Union meeting, and we attended the 205th anniversary of that school. It is the oldest pharmacy school in the US. While there, we had our first edition, Christopher, in 1985. And I'll just point out in this picture, he is small and my hair is jet black. And as he got bigger, my hair got grayer. And it was a cause and effect relationship. So by the time he was off to college, I was like, are you sure this is our boy? But from the slide here, you can see that there's absolutely no plausible deniability. Indeed, I did have to pay for his college education. From there, from Philadelphia, we're off to Buffalo. We shuffled off to Buffalo, where I did my fellowship in pharmacokinetics and infectious diseases. And that started in 1986 at the Millard Fillmore Hospital. This hospital no longer exists, right? Which is too bad, but that's the way things go. We had our second edition in 1987, and you can see in this photo a very happy Alicia and a very happy mom. You have to watch kids because they'll gang up on you, and these look very dangerous in their Easter outfits. So having been a student, an intern, an extern, a resident, and a fellow, which either paid nothing or half of a salary, Sue was like, hey, could you get a real job this time? So I did, and that was at National Jewish Hospital in Denver, Colorado. And my job was to come up to speed because they already had the all-star team working there. This is a slightly later picture during my career there. Not shown here is the Mother Teresa of tuberculosis, Marion Goebel. And Dave mentioned Leonid Heifetz. He's the individual on the left, and then the tall guy in the back is Mike Eisman. Two people who were very influential on my career. And the person in the front is Jim Cook, the head of ID who hired me there. So timing is everything. In 1992, the cover of Newsweek had two letters on it, TB. And it turned out that at that time, there was only one pharmacist in the entire country who was studying TB and developing tools for pharmacology and TB. Who knew? So luck is when preparation meets opportunity. And so as TB hit the proverbial fan in the United States, I got real popular real fast. So I was able to get an FDA grant, a CDC grant, an NIH grant, and an industry grant. Dave has already mentioned Roger Jelliff. In 1993, I got a postcard introducing a course at the University of Southern California on population pharmacokinetics, which was the up and coming tool to be used for pharmacokinetic data, and I didn't know how to do it. So I thought, well, probably should take this course. So I flew out to USC and took a few-day course there with Roger. We became friendly. We worked on a grant together, and we got the grant. And that started a long working relationship with a person who turned out to be one of my key mentors during my career. If you want to read more about Roger's work, here's a book by Roger and Michael Neely. Michael is now the head of infectious diseases at the Children's Hospital of Los Angeles. So here are three types of learning. When I was at the University of Connecticut, I lived in the library and I had this Goodman and Gilman's, The Pharmacological Basis of Therapeutics, tucked under my arm, going to and fro the library. And that was one form of education. Once I had a lab and I had to hire people into the lab, I needed a new form of education. And here's a good book about such things, The 7 Habits of Highly Effective People. And when I wanted a break from all of that, I would turn to things like Douglas Adams and the Hitchhiker's Guide to the Galaxy. And the most important thing I learned from that is SEP, somebody else's problem. A couple of key papers I'll share with you. One is How to Swim with Sharks, a primer by Voltaire Cousteau, though that's not his real name. And some of the key highlights here were assume all unidentified fish are sharks. Do not bleed if attacked. Counter any aggression promptly and use anticipatory retaliation for sharks with short memories. Another key paper is Understanding Academic Medical Centers, Simone's Maxims by Joseph Simone. Institutions don't love you back. Institutions have infinite time horizons, but you have a very finite time horizon to accomplish your career goals. Leadership really does matter, and team compatibility is grossly underrated in faculty recruiting. Now, I never met Joseph, and he actually started the cancer center here at the University of Florida, but his daughter did her infectious disease fellowship at National Jewish for a couple of years, so I know Patty pretty well. Leadership does matter, and here are some of the leaders that I worked with when I transitioned from National Jewish to the University of Florida in 2009. Julie Johnson and Glenn Morris in the top row, Reggie Fry and Hartmut Derendorf in the bottom row. So now you know how we got here, and now we'll turn to something entirely different, PK pearls. Some of you have seen some of these slides before, but hopefully they will bear repeating. So here are 3 different components that we can think about in the area of pharmacology and specifically PK and PD. So on the top left, you have a concentration versus time curve, and you can see underneath it, an area is described. So that's the AUC, or area under the curve. So pharmacokinetics is what the body does to the drug. On the top right, you have an effect versus drug concentration. That's pharmacodynamics. So you start with no effect, you go up a steep slope, and then you plateau out. And if you combine those two, you have PK PD, which is the effect over time. You've probably seen this before in some version. Here we have, again, a concentration versus time curve. This is the PK part of it. And then we're going to relate that to things that are the outcomes we're looking for, either the good ones or the bad ones. So we have the minimal effective concentration, or MEC, and the minimal toxic concentration, or MTC. And you want to stay between those two so your drug is effective, but not by a concentration-related mechanism making your patients sicker. So what game are we playing? We're playing the concentration gradient game. So you have to get drug into the blood. And if we take oral drugs, it's got to be dissolved in the stomach and then moved to the duodenum and the jejunum. And from there, it's absorbed for most drugs. And then from there, it goes to the liver, and then to the heart, to the lungs, back to the heart, and then to the whole body. So any disruptions in that process, and you're going to have low concentrations. If you have low blood concentrations, then you're not going to be able to drive the drug to ultimately where you want it to be, and that's where the pathogen is. And it varies depending on which pathogen you're trying to treat, where they might be hanging out. So if you don't establish that concentration in the blood, you can't get the drug to the pathogen. There really is no substitute for that. And this is what we're trying to control with pharmacokinetics. As Dave was mentioning, apparently not all people are the same. If they were, you would go to a shoe store and there would be the shoe. Let's say it's a size 10 men's black shoe, but everyone's foot would fit that shoe. But that's not what you see when you go to a shoe store or any other type of clothing store. There's all kinds of sizes and shapes and colors because not everybody's the same. This is the normal distribution. You learned about this in high school and probably again in college, the Gaussian curve. And about 68% of the population is within one standard deviation of the mean, which is the middle line. And then you go out to 2 standard deviations and you're roughly 95%. And then there's the tails of the curve, right? So this is reality. It doesn't have to be a perfect bell shape. It could be skewed one way or the other, but you have a distribution of pretty much everything in your population. Blood pressure, height, weight, you name it, there's a distribution. When you give one dose that fits all, theoretically, like 600 milligrams of rifampin, it's in the guidelines, that's the dose. Well, you're basically saying that the two ends of the curve don't exist. You're just blocking them out, and you're treating the middle 68%. If you're lucky, maybe it's 75%. If you're not lucky, it's only 50%. So that's the goal, to try to treat everybody in the population, not just the middle portion of the population. Now, if you've played the pharmacokinetic game with us, then you probably heard some of these things, and I'm going to review them, and then we can open it up to questions about, why this or that. So the one thing we often insist upon whenever possible, and we understand there are situations when it's not, but we try to get 2 samples because we're trying to get a trajectory. And if you only have a single sample, you don't have a trajectory. And you also learned this in high school. Infinite number of lines or trajectories can pass through a single point. So you need a second point to try to pin that down. And this is what we're trying to pin down. Usually with the oral drugs, we're trying to see if it's getting in either on time or slowly. Right? So why would it go in slowly? Well, some people have gastroparesis due to diabetes, and that would be one reason. Or even if an otherwise healthy person has their TB drugs and then immediately eats a high-fat meal, say a Big Mac or a Whopper. So now you've added a bunch of fat and protein, and your stomach is going to go, time out. Nothing moves to the intestines until all of this stuff is liquefied. And that's going to take a while. And there you're going to get delayed absorption as well. So here on the graph, you see what we're hoping for, the green line, the normal absorption pattern, where the drug reaches a peak approximately 2 hours after the dose. And it varies by drug, but that's a good ballpark. And then it declines from there. So theoretically, this would be in the normal range for this hypothetical drug, and that's a happy situation. Now, the blue line is not so bad. It's slow, but it does get into the system eventually. And in this case, the 6 hour concentration is higher than the 2 hour concentration. And then the red line is bad. That's malabsorption. And it's just going in one end of the patient and out the other end and not really getting into the blood. And then you never get that concentration gradient to the pathogen. Now, in certain situations and for certain drugs, people are truly enamored with getting a trough concentration. Unfortunately, for most drugs, the efficacy or even the toxicity of the drug is not driven by the trough concentration, it's driven by the area under the curve. Now, the simplest possible area that you can draw is a triangle. And here we have three different ones. We have the blue one, and we'll just say that's normal. And then the orange one, and we'll say that that's half of normal absorption. And then the gray one, which is clearly bad and would potentially qualify as malabsorption. But you see, they all have the same trough concentration. Why? Because these patients, these hypothetical patients, have different volumes of distribution and different clearances of the drug, and they all end up at, say, 12 hours or with a TB drug at 24 hours in the same place, but they didn't start in the same place. So we really want to know more than just the trough concentration to understand what's happening in our patients. Now, how can we approach that? Well, in a phase 1 drug study, you might get 16 samples within a 24-hour period through an IV line. We're not going to do that in the clinic, and we usually are stuck with only 2 samples that we can get, maybe 3 for a certain drug like linezolid. If you take the concentration starting at the peak and then plot them, you'll get a curve, right? Especially if you have more than 2 points, of course. But if you plot the log concentration versus time, it becomes a straight line. And now that's a pretty easy thing to deal with. And again, in high school, you learned y equals mx plus b, the formula for a straight line. We use a version of that formula. So here, if you have a 2 hour and a 6 hour, you could back calculate to, say, 1 hour if you thought INH was absorbed within an hour, or 30 minutes if you're giving an intravenous drug like amikacin, which is rarely used these days, but nevertheless was used quite a bit for MDR-TB. And based on the reports that we just heard, maybe we're going to have to go back to it if we're getting pan resistance to the BPAL regimen. Anyway, with a simple 2 points, you can calculate back to what could have been the peak and forward to when the drug is going to be gone from the plasma. A few practical points about this. How fast do you need to freeze the samples? Well, normally you want to centrifuge them and freeze them as fast as possible. But what if you have to drive out to a rural area and do the blood sampling there? Well, if that's the situation, then you can use green tops. You can actually use purple tops as well with no gel in them. And you gently invert them to mix the contents, whether it's heparin with the green top or EDTA with the purple top, and that's an anticoagulant. And then you can immediately put it on ice chips, which are easy to find almost anywhere. And then you can transport it back to the lab where you're going to process it, but it'll stay cold during that time period. You can also do this with a red top tube, which has nothing in it. It's truly just a vacuum. But you have to let it clot first. And that's going to take 15 to 20 minutes. And if you're back in your car, you're not thinking about it, you might forget to do that. So if that's the situation, I would use a green top. How to ship them? Well, there's different carriers. In general, the U.S. Postal Service does not have a true overnight delivery service. So I would not use that service. I mean, it can get there overnight, but they don't guarantee that it'll get there overnight typically. There's UPS and there's FedEx, DHL. The one that we get most of our samples through is FedEx, and they deliver right up to our laboratories. The others often leave the samples down at the loading dock, and we have to go looking for them. So, for practical purposes, we find that FedEx meets our needs the best. How long does it take to get results? Well, we will give you your results within 7 days, right? And most results are usually within 3 days. some assays, like the beta lactams that we measure for our intensive care unit here, we run them Monday through Friday. For the azole antifungals, we measure those Monday, Wednesday, and Friday for the transplant clinic and the oncology clinics. And then the other drugs we measure usually once or twice a week. For the rifampin, isoniazid, pyrazinamide, and ethambutol, we typically measure those on Tuesdays and Thursdays. So most of you will get the results within just a couple of days. Linezolid is the poster child for TDM, followed closely by rifabutin, but now linezolid is the poster child because if you don't give enough of this drug, then it's not going to work. And if you give too much of it, you're going to get either anemia or peripheral or ocular neuropathy, all of which are bad. So it also turns out that this mitochondrial poisoning, specifically the first sign usually is anemia, that is correlated with the trough concentration quite well. So whether it's exactly 2 micrograms per mil or 2.4, different labs have picked different trough concentrations, but we picked 2. And if you keep the trough concentration below 2 micrograms per mil, you usually will avoid those toxicities. So of all the drugs that I would recommend for TDM, linezolid is at the top of the list. If you want to read all about it, you can pull up this paper from 2016. You should be able to find it on PubMed pretty easily. So to conclude, the decision to use therapeutic drug monitoring is the same as the decision for any other clinical test. Complete blood count, chem panel, sputum sample testing, or the decision to get a CAT scan or an MRI. None of the results from any of those tests guarantees that the patient is going to be cured. I mean, nobody ever asks, well, how many sputum samples do I need to get to cure the patient? You'd say, well, that's a silly question. It really is a silly question for TDM. What TDM allows you to do is make informed decisions about the dosing and increase the probability that you're going to get drug to the pathogen and cure the patient. Ronald Reagan, a Republican president at the time when Republican presidents were not painted orange, had a favorite saying, "Doveriez no proveriez," trust but verify. So I'd like to thank the team in my laboratory, TJ Zagurski, Kyung-Mi Kim, Brooks Nelson, Stacy Stoneberger, Sarah Rivera, and the new director of the IDPL, Nicole Moranchik. Here are those little babies that I showed you, all grown up. That's Chris on the left, Alicia in the middle, and her husband Dan on the right. And I'll point out Alicia is 5 feet 10. So her brother is a big boy. So we can prove that we fed them, just saying. And there's the mama, there's Sue. So thanks to my family for putting up with my excessive work hours, and thank you for paying attention.
Chuck, that was unbelievable. Thank you very, very much. I appreciate it. What we'd like to do now, if it's okay, is like we'd like to open this up for questions, discussion. This is really not supposed to be necessarily all didactic. It's okay to open this up and share your stories, your experiences, and of course, we got Chuck for 30 more minutes. If everything goes right, the handcuffs are not going to be released. He is, as you know, chained to that chair. And I think he's not being deported for another couple minutes, right? Yeah, we have a couple more minutes, Chuck, before your plane leaves, right?
I believe so.
So, Chuck, first of all, I think the question that everybody wants to know is what is the air velocity of a unladen swallow?
What do you mean, African or European?
So, Chuck, do you remember? Do you remember? I kind of think it's kind of funny. It was a really weird class. I don't know what was special about that 1993 class, but I remember being out there and there was quite a number of participants and also lecturers and mentors that all met there. Tell me a little about National Jewish and what it meant to you, because it was a special place, I think, in the TB world.
Well, absolutely. So I mentioned the Mother Teresa of TB, Marion Goebel. And Marion was my mom's age, right? So going on rounds with Marion, she was very deliberate. And, we had the negative pressure rooms, but she was not afraid to go in there. And she would sit on the end of the patient's bed and talk with them pretty much like she was their mom, right? And the patients loved her. And, she would convince them, yeah, it's unfortunate, but you're going to take, cycloserine, para-aminosalicylic acid, ethionamide, and amikacin, and it's not going to be easy, but we can make you better. And they would do it, right? And we would get, people from all over the country. Some of them were, they would arrive there curmudgeons. But, when Mother Teresa started working with them, they would come around. And then there was Mike Eisman, who had a very deep voice. And Mike was fun to work with. And he was usually the master of ceremonies for the TB course. You mentioned John Sabarbro, who technically was not at National Jewish, he was at Denver Public Health. I would come in and talk about fun things like the PPD and what is that purified protein? It's mycobacterial poop, as he would describe it. Leonid Heifetz, we used to tease Leonid because he spent the first 50 years of his life in the Soviet Union and almost didn't get out of there alive on several occasions. And he's written a book that you can check out, which I found fascinating. It explained a lot to me. And Leonid had a very dry sense of humor. One time I invited him to give a talk at the American College of Clinical Pharmacy, and he was in his mid 70s at the time. And so he comes to the podium and he goes, it's not so easy getting older. First, you start to forget the names. Then you start to forget the faces. Later still, you forget to zip up. And later still, you forget to zip down. So Leonid was full of those kinds of things, and he was just a riot to work with. And then Jim Cook was only board certified in 3 different disciplines: infectious disease, general medicine, and immunology. Not so smart, And Jim was just a gem. He was just a great person to work for. And Gwen Hewitt initially came through as a fellow, stayed on the staff. I mentioned Patty Simone previously. And there was the whole crew at the hospital. It was a great place to work.
I guess the reason I'm asking you that, and please let me just remind you, we have some questions and we're going to get to your questions. And please do me a favor. If you guys want to speak to Chuck, just raise your hand. And what we're going to do is we're going to unmute you because Chuck deserves today to get a little whooping. I mean,
Yeah.
he's whooped us all for a long time. I mean, so it's time to whoop Chuck. So I'm
But
hoping that
if you
some of
ask
you
a
step up.
question, you go, oh, Mr. Carter, Mr. Carter.
Oh, I could see Alexis right now. Like she's like, oh gosh, I can't believe we're doing this. What's up, Alexis?
I'm listening and smiling. That was Hia.
Yes.
Hey.
Cutting
On
in
that
there.
note, Dave and Chuck, we do have some questions in the chat that some people
Right.
are posting. So Anna has a question. She says that their office typically tells patients to take a little bit of food before they take their TB medicine, even though the literature suggests taking it on an empty stomach. Do you have any thoughts on that?
Yeah, it's perfectly fine to take it with a light snack. What constitutes that? Well, a cookie, a graham cracker, something, a crunch bar. But I would avoid things that are loaded with fat and protein because it all comes down to whether, if it's simple carbohydrates, your stomach will take care of that in no time. And then the emptying into the intestines will happen pretty promptly. But if you put in something that's very complicated, that's going to take time to break down, that's when you get into the delayed absorption. So yeah, some people just can't tolerate the drugs on an empty stomach. Fine. Give them something, but get like a toast, something simple that the stomach can handle very quickly.
But that varies by drug, right, Chuck? I mean, there are certain drugs,
Well,
where
like
like Go ahead.
Rifapentine, you want to give it with food, right? And then bedaquiline, you want to give it with food. So, follow the package insert, as the saying goes. Yeah, for the RIPE, which is in the United States the most common regimen with some variations, for RIPE, normally empty stomach or a light snack, and you're pretty much good to go. That's different than the BPAL regimen.
So in
But I
that,
also think it's go ahead.
oh,
Go ahead.
sorry.
I'm sorry.
So in that same breath, we also had somebody else ask that would you recommend the first meal that patients take after they take their medication to be a low-fat meal?
Yeah, I mean, if they can do that, or you can give the drugs an hour before, and then they'll be pretty much on their way by the time the food hits the stomach. So it's not the worst thing in the world to give the drug with food, but as mentioned, it's going to delay things. And if you're only going to have time to get a 2-hour sample and you just gave them a Big Mac or a Whopper, you're going to miss the peak.
But I think you'd agree, Chuck. I mean, it's important that the pills get in the bellies.
Oh
Like
yeah.
if it's getting to a point that the person just can't tolerate, you're better off like giving it the way you can and then doing levels and adjusting for it.
Yeah.
And you also want to, you want to try to do it the way the patient's going to take it every day.
Yep.
So, in the perfect world, I think you'd agree. Everything you said is great, but sometimes we don't live in I mean, you can create the perfect world, through pharmacology, but sometimes we don't live in the perfect world, so there's another question about that. Like if you have a client that's on scheduled antacids or protein pump inhibitors, how long should these medications be held prior to drawing a TDM? And before we go any further, all these great questions, all these great questions. Chuck, what's amazing to me is you have been involved in studies that answered or at least gave us insights into that. I thank you for that. It's hard work. So what would you say about antacids or what do you call it, or proton pump PPIs?
Well, with the antacids, I mean, if you can, give them 2 hours after the TB drugs, you're better off that way. It varies, and the results have been published. There's some effect to no effect depending on the drug of the antacids on the absorption of the different drugs we use for TB. The ones you really don't want to do it with would be the fluoroquinolones. So even though they're not part of the RIPE regimen, they often
Yes.
substitute. Yeah, they often substitute for either isoniazid or ethambutol, depending on susceptibility or what the patient tolerates, right? So if you can postpone those for a couple of hours, and this would be every day, not just on the blood draw day, then yeah, usually especially I always suggest dose in the morning, potentially early, gives you lots of runway as far as times to draw your blood. And then you can do all these other medications that might possibly interfere. You can just do those later, right?
Hi, I think you were saying I saw something quickly pop up. Did you say somebody raised their hand or
No, but on a similar note, there was a question in the chat that said, with the increased use of GLP-1s, have you seen this affecting the absorption rates of TB medications and levels due to increased emptying or decreased emptying? I apologize.
Uh, I couldn't tell you because on our requisition, we don't have a space for GLP-1s, and I'm not aware that anyone's done a phase 1 type study. To really get the answer to that, you'd want to have healthy volunteers, and you would vary the sequence with which you did the TB drugs alone and the TB drugs plus a GLP-1 or any other drug, right? So as Dave was mentioning, we did some phase 1 studies back in the day, looking at fasting versus fed versus antacids. And you can easily find those through PubMed. And that's the study design. I didn't invent it. We just used it as a Latin square designs where you vary the sequences of the different tests. So you can check it out, and that would answer the how. But I'm not seeing anyway any specific study between some of the newer drugs used for diabetes and/or weight control and the TB drugs.
Yeah, I mean, I think it's a great question because, like, right now, as you know, the GLP-1s have, really pretty much dominated right now the pharmaceutical sales and use. And you are 100% right. I mean, one of the proposed mechanisms is that it causes delayed, emptying. So it does make sense that it might have. So whoever wrote that, that's a great NIH grant. Just email Chuck, and because he's going to have some time on his hands. So I'm sure that's what he's going to want to do, right?
I will have time on my hands because I'm already tired, and then by the end of this year, I'll be retired. But Nicole will be here, and then she will be flying the airplane at that point.
Another,
Oh, go, Alexis, please.
sorry, Dave.
No, you got
Another
it. Go.
question says, if you're only treating LTBI with rifampin, delaying the peak doesn't matter. So does empty stomach matter? I don't know if the mechanism was delay or binding of the drug, in which case an empty stomach totally matters. As for 3-HP, I tell patients to take after eating despite the INH because of the rifapentine. Is that correct?
Yeah, so for rifampin, again, it's just as I said for RIPE. If you can take it on an empty stomach, great. If you can't, take it on a light snack. Rifapentine is a much more lipophilic drug, and so it's better absorbed with food. Now, it will decrease to some degree the isoniazid, not horribly, but it does have some effect on the INH. But the drug that's driving the bus in 3-HP is the rifapentine. And my personal bias is that it would work even if the isoniazid wasn't there.
And there is studies looking at that, beginning
Yeah.
to look at just rifapentine
True.
alone. You're right. So so there's a question here that I really love, if I may. Dominique is saying, does your clinical site teach pharmacy students and residents? But before you answer that, that was really what I was going to get to with Nicole. And I've had the pleasure of working with Nicole. She's amazing. But Chuck, is it possible to reproduce another Chuck in 2026? How do you reproduce? Because back when TB was more common and you could actually be around a lot of TB patients, not only one of, I think, your great qualities is not only you an amazing pharmacist, but you're an amazing clinician. I always say this, like, what I love about talking with you is, I'm a stupid clinician, and you somehow can find a way to dumb it down enough for me. And when your insights clinically are amazing, and they only get better with time. I mean, I've been working with you for over 30 years. I mean, can we do that? I worry about that a lot. Like, where do we train our next, or how do we train our next generation? Because medicine's an art. You have to practice it,
Well, at Mayo, and I hope I pronounce his last name correctly, but John Zuhl is working with John Wilson and the folks there. So the different national TB centers now have pharmacists. So NAV is working up in Rutgers/New Jersey. So there are other people that are taking an interest in the field, starting their own research programs as well as clinical programs. I can't exactly speak to, how often and how many TB patients they see in a particular unit of time. They obviously could answer that for you. I mean, the good news is that, there's fewer TB cases than there used to be, because it was like 28,000 when I started annually. And then, now we're down to around 10. So that's good news. And even at National Jewish, they mostly see NTM patients now because there's a reticence to move TB patients around the country. So, it's a good point. You have to do probably a version of what is happening right now with Nicole Moranchik, where she got trained up on the pharmacology side of it, and now she's working with the Florida TB control units to attend the conferences, the patient care conferences.
I think that's really, and again, I'm really biased, obviously, but I think that's really is how do we get the patients to the clinicians? And I think with technology and what we're able to do, it's possible, but you can't learn medicine unless you practice medicine. And in order to practice medicine, you have to have patients. And in the United States, that's an unbelievable challenge. And on the other hand, Where there are patients, there's resource issues, as we've heard. And I think the resource issues are not going to get better. So, it's a real issue. Haya or Alexis, is there? Do you have a question? Because I can talk to Chuck all day long. Alexis,
Yeah,
got
so
some?
there's a few in chat. I was letting you guys kind of finish that up. There's a question here that says, if a patient is on hemodialysis, is there an ideal time for the SDL for the EMB and PZA in terms of timing during the initial phase?
See, Alexis, we did this on purpose. You've been making fun of me and Chuck the whole time. We've been
I
making
know.
sure these questions you are saying things that are hard to pronounce. We've done it on purpose to you, Alexis.
Yeah.
Chuck, I'll let you go.
So we've actually published on that. So you can find papers that we've published on patients on hemodialysis. Hemodialysis doesn't have a really big effect on some of the TB drugs, like rifampin. It's too big, doesn't really get pulled out very much. The smaller drugs, you'd expect a bigger effect. But typically what you'd want to do is do your hemodialysis and then give your TB drugs. And for drugs like PZA and ethambutol and probably levofloxacin, where there's a large renal clearance component, you probably want to give those drugs only 3 times a week, right? So I would just, do the hemodialysis and then dose the TB drugs like right at the end of the hemodialysis, and then you can get your 2 and 6 hours, because now you're not really worried about the clearance, you're worried about the absorption. A lot of the patients who go on to dialysis have diabetes, and so they have gastroparesis if they've gotten to that stage, and so they may have difficulties absorbing the drug. One thing I will say, if the patient's on peritoneal dialysis, do not use ethambutol. It's not removed.
Peter
so-
Segal. Oh, go ahead. I'm sorry.
No, sorry. Go ahead, Dr. Ashkin.
No problem. Peter Segeski. Hey, Pete, first of all. But he asks a great question, and I think it's really a question that you get asked a lot, which is, so Chuck, putting you on the spot here. So how much essentially what he's asking is, how many patients do you think, or what percent of patients do you think actually get cured because of TBM? And separating it out by, drug resistant versus drug sensitive. But I think that's something is, what is the role of TDM? Is it for everybody? Is it for a select few? What is the role? And I think that's Pete, if I messed that up, please just jump on and I'd rather hear it from you. But I think it's a great question.
So, no one's going to do the giant TDM study, the prospective randomized clinical trial, right? That's just going to be totally unwieldy, way too expensive, and nobody's going to do it. We did a small study looking at 2 states in the Southeast that do TDM all the time and 2 states in the Southwest that don't. And the patients who did get the TDM became culture negative faster. So that would argue that it's having a positive effect. I mean, if we just take a step back, if the drug's not in the blood, it's not working. So that's pretty easy to figure out. That would be a bad situation. And then we have, how long does it take to get people completing their therapy? In the US, the CDC doesn't track cure, quote unquote. They track completion of therapy. And it's still hovering around 89% at 1 year, not 6 months. So there's a lot of reasons why that happens, including people absconding from treatment, having other things that have to take priority, like maybe cancer chemotherapy or all kinds of things. Interruptions do happen. But a portion of that is the patients got underdosed and you had dribbled in the drug over a longer period of time and eventually cured them, right? So I can't say for sure how much TDM contributes. But, why do we do chest x-rays? Does a chest x-ray cure the patient? No, but it allows you to look inside the patient and see how bad the problem is, and then make your decisions based on that. You might even send them to surgery. So TDM allows you to look inside your patient and make a decision. Am I comfortable with where the doses are? Am I giving too much drug and I need to back off? Or do I need to give more drug, which we find is the more common problem, especially with rifampin, and give enough so that the patient has the best probability of cure. But as you know, it's a complex disease with a large immunological component, plus different ranges of susceptibility. People can have more than one strain inside of them. So there's a lot of factors that can play into it. So I don't think TDM will not be the definitive thing, but it contributes to the cure.
Yeah, but I would like to just add something to that because I totally agree with you. But I think what's important about tuberculosis and what's really important as clinicians is if you look at studies, studies are always looking at how do you treat the most people? How do you cure the most people? As clinicians, I'm not in the business of curing or treating most. I'm in the business of curing and treating all. And I think that's one of the things I find TDM to be. I think you made a great point about, most things, if you look at for 68%, let's say, with one standard deviation, you'll get it. But I'm not, as a clinician, I can't afford one standard deviation. I need three standard deviations, and I think that's where TDM takes you. And on the other hand, just like you said, a lot of times we play the limbo game, and especially in patients, we talk about efficacy, but a lot of times we get into problems with toxicity, and you get into that limbo game with how low can you go? And I think you're 100% correct. I mean,
Yeah.
but I think that's a question you always have. You've had for 30 years, I've heard you defend it, so I wanted to give you that point again.
Sure. And recently at some of the national meetings, including the NAR meeting that just occurred. So Bill Berman, who was a colleague in Denver for many years, and it was great to see him again. He's pointing out that the TB population in the United States tends to be an older population, and they don't tolerate these drugs
That's right.
all that well. And
That's
probably, the least tolerated of the RIPE is the pyrazinamide. It's not a fun drug to take. But isoniazid and pyrazinamide, and to a substantially lesser degree, rifampin can cause liver toxicity, and it tends to be more common in the older population. So he is of the mind to be more gentle with the older patients because they simply may not tolerate it, and you're really trying to get them through the whole treatment. So there's always a
And,
balancing act.
yeah, and your other colleague Kevin Fenley. I mean, it goes on and on. The National Jewish alumni, but he showed that PCA in older individuals, like you said, it's very poorly tolerated. But maybe we don't need that dosing. And one of the things that's interesting about PCA to me is it's so well absorbed. I think we overdose people personally, but that's me. Hey, we have a couple more minutes, and what I'd really like to do now is if there's somebody who wants to say hello to Chuck, if you guys would just raise your hand, and please, if you're going to say something, don't be nice to him. Everybody's so nice to him. Don't be nice. So, hi,
And
Alexis. Anybody want to? Do we
Yeah,
have
so
somebody?
Yeah, yeah. Oh, sorry. Here. We do have Connie with her hand raised. If you're
All
ready to
right,
go, I will allow her to talk.
go, Connie, go. How you doing?
Hey there.
Hey,
How
I love people. I love people who go by first name. I love it that Connie, and we all knew who it was. That is how close we are in the TV community. Connie, how's it going? Please go
Hey
ahead.
boys, good to see you both. Hey Chuck, enough of this science stuff. I want to get to the mushy part. I wanted to tell you how much I appreciate you. You have been such an amazing, amazing friend, mentor, resource to me. I have loved teaching with you, doing some studies and writing with you. You have 100% made me a tremendously better clinician, and I'm just so glad you're my friend. And don't try to hide. I will be finding you. And you are always, always welcome in Nashville. I've got a bed for you and Sue, and maybe even a pair of boots and cowboy hats. So
ooh, it's very hard to turn down that. Yeah. So thank you. That's very sweet. Yeah, and it's been a fun time working with you as well.
you are
Connie, thank
one of
you.
a kind, and I'm excited to work with Nicole, but I'm gonna miss you terribly.
Thank you.
Connie, thank you so, so much. Thank you. All right. So, Alexis, who else? Or hi, who else? All right. So, what I can tell you is that just this morning, I spoke to Chuck Daly, another one of your infamous criminals that you, I mean, no, accomplices, or
Compatriots.
right. No, and he says he's sorry. He's speaking to you for World TV Day, but he wanted to send his regards. So
Well, it turns out that at 5 o'clock Eastern time, I will be participating in the Colorado World TB Day. So it's the gift
Well,
that keeps on giving,
well,
just like
please,
TB.
Chuck, I'm going to give you the final words. I just want to thank you so much for being, seriously so willing to do this and brave, because you didn't know what you were getting into. I've been nice to you, Chuck. Please be nice to
Mostly.
me. But but I'll give you the final words and then we're going to close it up. But Chuck, thank you very much for everything you've done and everything you've meant to everybody. You are amazing. And I like to say we're going to miss you. We won't. But go ahead.
So, first of all, per Frank Zappa, don't eat yellow snow. It's not lemonade. And then, secondly, according to the Grateful Dead, what a long, strange trip it's been, right? But I've thoroughly enjoyed it. I would have never thought I would have been in the TB business when I was in undergraduate school. Getting my bachelor's degree in pharmacy wasn't my favorite topic, even in grad school, not my favorite topic. But, it was a good job. Sue and I wanted to move to Denver. We did. We picked up the two little kids and off we went. And then, things just fell into place, right? Luck is when preparation meets opportunity.
Chuck, we thank you. I'm going to turn this back over to Karen. Before I leave, we want to thank you so much for everything you do every day for our TB community, our TB patients, and we're there for you if we can be of any assistance. But again, thank you, thank you, thank you. Karen, it's yours.
Thanks, Dave, and a great thanks to Chuck for your many years of assistance to SNTC and all the folks that have joined on the webinar today and beyond. And thanks to Philip Wegner for joining us today too. We appreciate your overview of the new data that was released. Thank you so much, everyone, for joining today and letting us recognize Chuck for all of his years of service. Have a wonderful World TB Day. We hope you celebrate. Go create a TB avatar like we've done. And we hope to see you at one of our trainings in the future. Take care, everybody.